Hi, my name is Doug Carey and welcome to this second Dry Needling and Acupuncture Student Information webinar. I still encourage you to view the first one because of the good clinical information contained within it, but I wanted to update some sections and hence this new webinar. That's the point behind this evening, is really to get you to have a chance to have a think. You probably had to think about what acupuncture and dry needling is, and you might sort of wonder where does it fit, because you are in what years? I know we've got a fourth year, but what about the rest of you guys? All fourth years. So oh, Justin's not. Third as well, and all fourth. You're all, who's Gems? All of you. So all the senior people sit there and all the juniors. Is that the way it goes? Okay, so what is acupuncture? Well, acus means needle and puncture is prick. So literally it's a needle prick sensation. Now when we get beyond that, that can mean a lot of things. We've got wet needling classification, so our botulinum injections, our celestone, lignocaine, steroid, dextrose. There's a lot of wet needling that's done, obviously usually by doctors, because most of the stuff they're putting into somebody is a substance which requires a prescription. So that's what wet needling is. Traditional needling is looking at the Chinese, Japanese and Korean, so you've heard of traditional Chinese medicine. As part of their paradigm of treatment, they will use needles to stimulate the meridians, increase the qi or decrease the qi and energy flow. So that's what they're looking at. Japanese and Korean are similar, but they tend to use much more superficial needling, so it's only 5 or 10 millimeters depth, whereas Chinese needling is deep needling. It can go up to 6.5, 7 centimeters, like in a piriformis or something like that. There's a point there that they go for. Then we've got the sort of duality of dry needling as opposed to wet needling. So some ones that we sort of don't really get into are tattoo and body piercing, but there's still acupuncture in some sense. It's just that they're putting a stud in, or they're putting some ink in addition to the needle, but it's still a needle prick sensation. Then we've got a more standard trigger point work, which is called dry needling in a sort of medical sense. We're looking for trigger points, parts of the muscle that are in spasm, and we use the needle to evoke a response in the muscle to bring about relaxation, increased circulation, pain relief, that sort of stuff. And then Western medical acupuncture is kind of a blend between the dry needling and the traditional Chinese medicine acupuncture, where with things like real-time MRIs or encephalograms, they can actually map the brain in 3D either visually or electrically, and by putting needles in certain what are called strong points, they'll see certain areas of the brain provoked that are relating to pain relief. So your periaqueductal grey matter, nuclear raphe magnus, those sorts of things, thalamus, that are associated with pain modulation. They put it in that particular point, so large intestine 4, they get a provocation in certain pain pathways, and they'll put one nearby in a non-traditional Chinese medicine point, and they won't get the same pathways lighting up. So that's where they're starting to combine what was initially considered old traditional medicine with sort of new stuff based upon both research but also on the new imaging and scanning that we can do of the brain in a real time. Okay, so as far as what is the difference in a clinical sense, this is a little bit of a tongue-in-cheek example, but this is sort of what reflects traditional Chinese medicine acupuncture.
呢正就好，呢正就好。我睇你明明老死，我你落針，一百我你做後生你跳啊，我睇你。你明叫我你唔會學那硬魔你背。做咩我跳魔嘅歌？可能。我做聲聲聲就過。มีไก่วงห้วย
Okay, so in traditional Chinese medicine, you tend to have about 10 to 15 needles, and you're often lying down and you stay in that position for up to 20 minutes to half an hour. So it's a slow stimulation process, so that is a bit exaggerated, but when you get out there in the marketplace, people that have dry needling tend to have 1 or 2 needles placed in, and they might be moved around a bit, but you don't have that sort of full range of needles that are placed in the tissue. If somebody has that, then they're usually having traditional Chinese medicine. So if we break down the dry needling area specifically, which is what we would be looking at as physios, is you have superficial and deep. And superficial is about 5 to 10 millimetres of depth of penetration. So we're talking skin and subcutaneous tissue. When we're looking at the deep needle insertion, we're talking anything up to 7 centimetres. And we're particularly going for depth in relation to the tissue that we're targeting. So if we're after gluten in, you can't get to gluten in unless you go 5 or 6 centimetres, because that's how deep the muscle is. If you're looking at something like extensor digitorum, it's only 5 or 10 millimetres at most. So the depth is based upon what you're going for, and you're targeting a particular tissue because of your assessment. So you do your normal biomechanical assessment as far as subjective, your objective, active, passive, isometric, palpation, and as part of your palpation, you would palpate the tissues you suspect to possibly be causing the pain, localise the taut band, and then you'd be needling that. So you follow through on your normal assessments. The tools that we're using are a stainless steel dry needle. It's a single use and it has a plastic or a metal top. Because it's stainless steel, there is the possibility of irritation. Now, what are we treating? Well, we're looking at a thing called myofascial pain syndrome, which is a set of sensory, motor and autonomic signs and symptoms associated with the trigger point. Now, because it's a syndrome, we don't have a specific diagnostic test. So if you've had a heart attack, they whack you on the ECG and they can see your pattern of your heart wave. There's a big blip there at the A wave, it's inverted or something. They say, oh, you've had a heart attack, it's not working anymore. Or if you've got rheumatoid arthritis, they'll take blood tests and they'll see your rheumatoid factors are way, way elevated. And they can sort of say, yeah, you have a condition called this based upon our particular test. But with myofascial pain syndrome, there's no one test that says you've got it or you haven't got it. And it's really a group of symptoms. And so what we're looking at is some features that are common to a lot of people that have myofascial pain syndrome. One is this tender point in a taut band. So your palpation skills are going to be looking for a taut band. You're going to move along the taut band and you're going to find the hypersensitive spot, and that's what's called the trigger point. Usually it's got a predictable pattern of referral. So if you look in trigger point manuals, they often have these pain pattern diagrams that you can look at, and they're usually brought about by saline injections. So they inject saline into normal people and they look at the map of where the referral of pain goes to, and that's considered a sort of a classical pattern for that particular muscle. Most muscles have got particular patterns. The problem comes about when the saline leaks into adjoining muscles, and so you get a multiple referral pattern. So you don't take those too seriously, but you just be aware of them. You can also get a local twitch response, particularly when you place a pin into that taut band in that hypersensitive spot, and we'll probably see somebody tonight, if they're going to volunteer, we might see a local twitch response later on. Often the pain recognised by the patient, so their familiar pain is another thing that you guys would be describing when you're doing your subjective assessment. You're trying to get from your patient, what's the pain, what are the characteristics of the pain, under what situations do you get that pain. And then sometimes you get other things like a restriction of range of motion, and that comes about because if the muscle's got a trigger point in it, the band is taut, usually the muscle doesn't have full extensibility, but not necessarily, so you don't hang your hat on that. You may have weakness of the muscle because again it's not functioning as it normally would because of the sensitivity in the muscle, but it doesn't have atrophy usually. Why would we have atrophy in a muscle? What sorts of situations would bring that about?
Disease or something like that, muscular dystrophy disease.
Yeah, so a disease process that is affecting
some protein or something.
the nerve. Yeah, so if you're looking at, say, someone has a disc protrusion which is quite moderate and it's putting pressure on the sciatic nerve, the neural input to that muscle distribution is not going to be normal, so it'll atrophy. Yeah, so any nerve compression will cause an atrophy of the muscle. We don't have a nerve compression, we just have a trigger point within the muscle, so we don't get atrophy. And you can sometimes get autonomic symptoms as well in association with the trigger point. And one of the common ones there that throws people is that a lot of people will present with pins and needles and numbness as one of their subjective characteristics of their trigger point. Now most, and this is going to physios as well, if you have a patient sit down and describe to you, oh, I've got pain here, and it goes to there, and do you have any other symptoms? Oh yeah, I also get pins and needles and numbness in the area. You know, the little ears go doink, and their brain's going, all right, nerve compression. And that's what they're often thinking. But it's not true. Very few people actually have a true nerve compression of the people that have pins and needles and numbness. If they had a nerve compression, what else would you be looking for to confirm that?
Sensory loss?
Yeah, so an absolute sensory loss. So you'd say, so if I pinch you there, you can't feel it. And they usually say, oh no, I can feel that. So they have a sensation of paresthesia, but they actually haven't got a sensory loss, have they? What else could we test to confirm they actually have a nerve compression? Yeah, so your deep tendon reflex, your myotatic reflexes is another hard neurological sign that you test for a person that has a neurological deficit. And there's one other one. Yeah, so you look at your motor levels. So your strength, your reflex, and your actual sensation losses. And you could also slip in there, although it's not considered a standard test, but even neural tissue provocation tests. If you've got a nerve that's compressed, it's also going to be sensitive, and that means that if you did a slump or a straight leg raise or an upper limb tension test, provocation test, you'd expect that also to be positive. Although it wouldn't be specific to a level, it would just be specific to the nerve, so it might be 3 or 4 levels associated with it. Okay, so they're some of the features that we see in regards to a person that has myofascial pain syndrome. Now there's also this thing called the somatovisceral reflex, when we've got trigger points in and around the abdominal muscles. And it's just to sort of raise your awareness because, again, it's not very common with physios. We don't sort of think of ourselves as treating abdominals. We tend to more think of ourselves as treating musculoskeletal systems, but the abdominals don't seem to really register on our radar. And that's a shame because there's a lot of symptoms that patients will complain of that might sound organ-based, but actually coming from trigger points in the abdominals. So there's lots of stuff written about people that have increased pain during the passage of urine or during their menstrual periods. They might have reflux, they might have ongoing belching, they may have pain that's residual even though they've had their gallstone removed or their gallbladder removed, and it's often due to a trigger point in the obliques, external, internal, rectus abdominis or transverse abdominis. So yeah, just to be aware of it, you are allowed to palpate the abdominal muscle wall and see if there's any sensitivity in that area, okay? So I'm getting to you young, so you can think about it. Okay, so myofascial pain syndrome therefore comes with a variety of presentations. There's no classic presentation for myofascial pain syndrome. And the other unfortunate thing is that we actually don't know why we get a trigger point. It's completely unknown. There's a theory, integrated theory, which is that a muscular contraction brings about a dysfunction of the motor end plate that results in a muscle hypoxia, so it's under constant tension. With the muscle hypoxia comes irritation of the tissue, so if you starve a tissue of its blood and its oxygen, it starts to complain. It starts to release our neural peptides like substance P and calcitonin gene-related peptide. And once those sensitizing chemicals are released, you know, the ball is rolling down the hill pretty quickly. So that's integrated theory, but the question always comes back to, well, why is there a dysfunction in the first place at the motor end plate? So that's one of the problems, and the not so integrated theory is that it doesn't accommodate for trigger points that we see in other tissues that are non-contractile, so ligaments, skin, tendons are all good examples and places where we see trigger points. And we also use needles to treat periosteal junctions, myotendinous junctions. So there are other areas that we use the needle to provoke an inflammatory reaction to bring about a healing response for a problem that's ongoing. So we don't really know why we have a trigger point in the first place. And the problem with that is, however, they are extremely popular, you know, very high population existent. So they say about 20 to 30% of the general population, but when you move into like different pain groups, headaches, pain management centres, then you find they're way up in the 70s and 80% of people presenting to a pain clinic will have the presence of trigger points contributing to their pain situation. So it really brings about a bit of a disparity. We don't know kind of why they are there or how they present or why they start, but we see them in the population in, you know, huge chunks of people, and then once we move into a pain group, they get even higher. So most of you will have latent trigger points in your extension digitorum because you've been studying so hard, and your upper trapezius will be sore as well. So they're trigger points that are present in a youthful population that have actually had no stress on you at all, and your life is all before you. So that's where we have the general population stuff, but we throw you into a car or off a horse, or do a headbutt with a beach from a surfing accident, and your incident level goes up much, much higher quite quickly. Okay, so how do we assess for a trigger point? Well, we know that in our subjective, it's a hypersensitive nodule. So often the patient is aware of, I've got pain. That's usually why they present to your clinic. About 95% of your patients will come in and their number one complaint will be pain. So they're aware of pain, and the characteristics of that pain tend to be that it's dull, it's deep, diffuse, and they actually have a hard time to localise it. So they'll say things like, yeah, it's about 6 or 7 out of 10. And you go, all right, so it's in your shoulder. Yeah, it's in my shoulder, 6 to 7 out of 10 most of the day. Where do you feel it? Well, it's in my shoulder. No. Front, side or back? And I go, well, I don't know, it's in my shoulder. And you think, well, if it's 6 out of 10, you'd think you'd know where it was in your shoulder, front, side or back. But the characteristic of a trigger point pain is that it's dull, deep and diffuse. And that's due to its neurological loop, where it's been felt from. And the nerve receptors that are picking it up, their characteristics are slow conducting, unmyelinated, and they go to the part of the spinal cord which gets lots of input. The organ input, skin input, muscle input, bone input. So the brain is actually not very good at dissociating out exactly where it is. A bit like two-point discrimination. You reach over to your partner on their back next to them and tap them like that with your fingers out far apart the neck, and they'll work out you're touching them with 2 fingers. But you head down to the low back and you might get 4 to 6 centimetres apart before they realise there's actually a difference in that you've got not 1 finger but 2. So our two-point discrimination is a good example of how our neural supply changes as far as its ability to detect and pick up things. And it's definitely the same thing with trigger points. So subjectively they talk about pain, they're not very good at localising it. Another little characteristic to look out for is if they've been on non-steroidals, it doesn't seem to have made any difference. So if a patient comes in and says, I had the pain for a few weeks, for a couple of months, saw the GP, gave me anti-inflammatories, has it made any difference? Nah, it's made no difference at all. Then I'm starting to think, okay, that's another indication possibly that we're looking at dysfunction in the muscle system. If they had a joint irritability, you would think the non-steroidal would affect that in a positive way. But if it hasn't affected it, it's another indication from their subjective to consider, maybe a trigger point. When we look at the objective, key thing really is palpation. I did mention you may have loss of range of motion, so that might show up. You may have a loss of strength, but they're very maybes as opposed to common ones. Your key thing is that you're going to listen to the history, you're going to work out that you've got to look at the muscle system as part of your palpation, and then you go through and you palpate the muscles. Now you're looking for muscles either centrally or at the attachment. So where a muscle attaches to a bone or blends into a tendon, that tendon joins to a bone, you've got an enthesopathy, and often you get an irritability at that junctional point as well. Trigger points can be considered active, which means they're symptom producing. So that's the person coming to you. Or they can be latent, which means they're not aware of it, but when you start palpating around, you'll find it, and they're sore on palpation. So what's your thumb actually doing to that person? What's it actually doing? Yeah, sort of. Your thumb is a stress. You're imparting energy into that person's body and you're looking for a response, aren't you? So what sort of responses do you get? You get a verbal response, or you might get a tissue response, like a twitch or a withdrawal or some sort of movement in the tissue. So you're looking to see, you're asking the question of the tissue, if I do this to you, how are you going to respond back to me? And that's a question you're constantly asking with your hands. So you're using your hands as little receptors. Input energy, what do I get back? If I put more, what happens? If I put less, what happens? If I turn you that way, what happens? If I add a little bit of this, what happens? So your brain is constantly trying to provoke responses from your client and confirm, deny your clinical diagnosis. So you're kind of always walking a pathway through that patient's body, trying to come to an end point where you say, right, well, as a result of this, 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 and this, that's what the problem is. And that's what clinical reasoning is. Because the idea is that from your subjective, you're going to have a pretty clear picture of what the patient's problem is, and you're going to the objective really to confirm or deny that. That's what you use your objective examination for. Other ways in which we can look at and assess, but not something done commonly in a physio clinic, would be vibrational ultrasound. Algometry, which is testing the pain pressure threshold, which is what your thumb does. When you push on a person, do you still do your R1, P1, R2, P2s? So you're asking the question, if I apply this amount of resistance, at what point does the patient complain of pain? R1, P1. And then you might do a treatment to that patient. In our case, we'd be put an acupuncture needle into that trigger point. And then you're going to ask the same question, tell me when the pain first comes on again. And you're looking for like at least a 50 or 60% improvement in amount of pressure that you can apply before you get to your P1. So that's a significant change in the person's sensitivity. So their pain pressure threshold has markedly increased. So use your thumb as an algometer. EMG, which is something done in research. Microanalysis. This is probably the first amount of useful information that we've got from research in the last 10 or 15, 20, 30 years for acupuncture or dry needling. It's done by Jay Shah and his crew of researchers, and what they did is they used a micro pipette. You have chemistry where you suck the fluid up and you drop it into the beaker and watch it blow up, that sort of experiment. Right, this is the same sort of stuff, but the pipette's as fine as your dry needle, which is 0.25 to 0.3 of a millimetre, and it's got a hole in it. And they stick it into a trigger point and they draw out a little bit of substance and they analyse that. And they look 2 or 3 centimetres to the side of the trigger point, the same muscle, and they draw out a bit of that and they do an assay and see what they've got in there. And what they found in the trigger point, if it was an active trigger point, was that they'd have a much lower pH, so it was more acidic, and they'd find a higher concentration of substance P, which is a neural peptide that you only get either through trauma or through neurogenic inflammation, which starts spinal cord and work down the nerve into the actual tissue. And as most people in upper trapezius, which is what they looked at, never had direct trauma, it's arriving through this pathway of neurogenic inflammation from the spinal cord. So substance P, calcitonin gene-related peptide, interleukin factors, all these sort of inflammatory chemicals are found in a trigger point, and then they would put an acupuncture needle there, get a local twitch response, and then go back in there and then micropipette it again, and they'd find that it all neutralised and gone back to normal within about half an hour. So now we can say that, a trigger point different to its nearby tissue will have a different chemical assay inside it, and that when you get a local twitch response, that will neutralise, change, or go back to a reasonable normal chemical assay. So we know there is definitely something wrong or different in a chemical sense. And we've also now found that if we look at a Doppler ultrasound, I think I've got a picture. Okay, so this is looking, sorry, question.
So it's only if you get the twitch that it neutralises and...
Yeah, that's what they found in their research. And some other sort of researchers that have not looked at that directly, but what they've tended to find is they get a better result in their client, in the intervention group, if they got a twitch response. They'll still get an improvement in the client group that didn't, but it doesn't seem to be as good. And that's one of the, for me as a needler, I'll tend to go for deep needling to try and get the muscle as opposed to superficial where they just go for the skin and subcutaneous tissue. Because the research would tend to favour, if you get a twitch, you're probably going to get a few more responses in the body from that. So this is imaging the upper trapezius. We've got a normal upper trapezius, a uniform muscle in a 2D grayscale ultrasound. Over here we're looking at colour ultrasound or colour Doppler, where they're looking at the blood flow through the muscle. This is in the upper trapezius where we have a hyperechoic, so we have a reduction in signal going through the actual point where the trigger point is. And when they look at it under colour Doppler, similarly, we have a reduction in blood flow through the actual trigger point. So they can image these points now and say, well, there's difference in imaging, there's difference in biochemistry, and when we put the pin in, this is what it's going to look at half an hour to an hour later with that reduction of the trigger point and an improvement in the blood flow again. So it's kind of interesting because now they can actually see it and they can actually measure it in some ways. It still doesn't tell us why did it start in the first place. Now, of course, you're always looking for the why. Like in clinical, you might have symptoms, that's fine, we can treat that, but we're always asking the question, well, why do those symptoms develop in the first place? Posture, habit, psychological, overload, we're asking that question all the time. Okay, so we're putting a pin into a person, so we obviously want to be a little bit aware of the safety factors of this. It's not something physios have done historically. In fact, it wasn't, we worked under the 1950 Physiotherapy Act here until a few years ago, and that was considered to say do not penetrate the skin in any way. And it's only been the last 5 years really that acupuncture and dry needling has been considered acceptable by a large proportion of the physio fraternity. So the beauty of it is it's inexpensive, it's very convenient and portable. You only need to have very little to do it. It's not you don't have to have a PowerPoint, which like most things today you need to have. Side effects are minimal when you compare it to drugs and surgery. And then some big studies looking at 10,000 or more patients, so large case studies, find the adverse effect rate is around about 8 to 10% of patients. Now, the adverse effects they're talking about are things like drowsiness and fatigue. You might have a little bleed, like a little blood blister, and you might have an aggravation of pain. So the fatigue comes about because the person tends to relax. There's an endorphin release, there's a serotonin release, which is another feel-good chemical. And if there's been a stress element to the condition, and often there is, that relaxation response can be somewhat more profound. The bleeding comes about because you're putting a pin into a person's body, and as you come out, there can be a small little capillary might get punctured on the way out or the way in, and you end up with like a little freckle, like a little coloured dot on their skin, a bit like a freckle. If it comes onto the top of the skin, it just pressure and taken away with a swab. If it stays subcutaneous, it just ends up with like a little bruise, like a little mini hickey. So that's sort of what it looks like. Serious complications, we're predominantly looking there at pneumothorax. So if people are needling in and around the chest wall, they need to have and be much more aware of how they do things. So their needling technique needs to be, importantly done correctly. But that rate's around about 0.005 per thousand treatments. So not many. We do have occasionally ones in Australia, and they're usually brought on by poor technique, people doing things that they actually haven't been taught to do. In Asian countries, the other problem they get a lot is infections, so bacterial, viral infections, and that's mainly because they're using the same needles and not going for the single-use sterile needle concept that we're using here in Australia. So to put all that into perspective, the West Australian Government here compiles an annual thing they call the Sentinel Report, and that's looking at all public and private hospitals. So they're looking at all the serious adverse events that occur on an annual basis, and they report them. So last year, when I got this out of the paper flying up with SkyWest, they had 56 deaths in one calendar year under medical observation and supervision. So I kind of figure that compared to what we do, they're a lot worse than us, and that's in a hospital situation. So consideration of the broader picture, even though needling is a bit different, the concept of putting a needle into a person is something that most people aren't familiar with. The safety of it is fantastic, and in the general practice of medicine, needling is very safe. But it comes down to you need to do it properly. So that's why in our situation we have a progressive training program. It starts off with an introductory course, covers the most important muscles that you would see in a clinical situation, but the easy ones, and then we go into specific advanced upper quadrant, looking at the head, the neck, around the front of the throat, the rest of the arm muscles. And then in the advanced lower quadrant, we look at the abdomen, the back, buttocks, and then the leg as well. So there's a lot of stuff they're all 2-day courses. And then once you've done those 2 advanced courses, you can come back in a year's time afterwards, and you're entitled to do the master's program at that stage. That's another 2-day course. But it really leads people through a pathway over a couple of years of getting their needling skills. And it's not just find the sore spot, whack the needle in and move on. It's very much learning about your anatomy. Your palpation skills will be something that will develop and will continue to improve as you start to handle patients a lot. And the key thing with that is that you're only measuring surface anatomy, topographical stuff. When you start putting a needle into somebody, you got to think depth anatomy as well. So you got to think your brain like an MRI or a CT scanner, and you're going down in centimetre layers, because you're no longer just pushing on a point, you're actually putting something into it. So you got to think skin, subcutaneous tissue, what does that feel like? Fascial boundary, oh yeah, that's going to be splenius capitis. Drop into that, that's soft. Next fascial boundary, oh yeah, now I'm into semispinalis capitis. Drop into that, should be about 2 centimetres. Now drop through that, I should hit the articular pillar. So you've got a mental picture of the person in a 3D rotational position rather than just touching the top and pushing down on it. So, you know, excuse the pun, but it sharpens your anatomy, you might say. So these are some of the abnormalities that we've got to be considering with these types of patients. These are all normal abnormalities, so 5 to 8% of the population will have a cartilaginous defect in the middle of their body, of their manubrium. Unfortunately, someone has died because the TCM practitioner put a pin into there because there's a move front channel that runs down the front, went through there, went into the heart, person died. So it's not something that we would be doing in our type of technique, but it's something to be aware of, that the human anatomy does vary. Same with the scapula. Sort of 8 to 12% of patients will have a deficient floor of the scapula, so you need to be aware of that. And then I reckon practically, if you just think about the people as they get old and osteoporosis, and you can probably remember the skeletons, you know, when you look at the scapula, those box of bones, it's pretty wafer thin on a lot of people, isn't it? So it wouldn't take much for a pin to go through a normal person, maybe in their 60s or 70s, that had a bone density problem as well. And this is becoming more of an issue as well as we move into the age of enlightenment. There are a lot more people that are having implants in all sorts of areas, and we don't want to let them down. Okay, so legally, where do we stand? Well, as physiotherapists, we've now moved on from the West Australian Physio Act. We've now got a national registration. So there's no restriction if you've done what we consider basic training in dry needling, and that's sort of a 2-day course. Or if you go on and you want to do TCM, it's a 150-hour course. TCM is obviously quite different to what we're doing. The dry needling is really just an extension of your normal hands-on musculoskeletal, ischemic pressure, massage, those sorts of techniques. You certainly have to improve your anatomy skills and your hands-on palpatory skills, but it's not that big a step or a leap of faith in a paradigm of understanding to do needling on top of what you already do. The title of an acupuncturist, however, is protected. So you can say I do dry needling, but you can't say I'm an acupuncturist. That's a protected title, just like I can't say I'm an orthopaedic surgeon because I don't have the training in that. Physiotherapy Board was developing some standards in regards to this, and this has been an ongoing process. They were going to do that by about 2 years ago, and they still haven't come up with anything. So that's the sort of work in progress by the sound of it. So you can be a dry needler, you can't call you acupuncturist, and hopefully at some stage the Registration Board will actually come up with a set of standards. What we're trying to do is self-regulate ourselves and show that we can say, look, everybody, it's a physio that's done dry needling, will have at least done a 2-day course. And we sort of stay within that as our basic starting point. And then it's like anything that you've done, if you need to advance that skill, you go and do training, you increase your scope of practice under an appropriately trained situation. If someone taught you thoracic manips, you would then start doing cervical manips. Different area, different set of conditions to consider, different pathology, so you need to be trained appropriately. You need to know what you're doing before you jump in there. Same thing with dry needling. Okay, so your malpractice insurance is just covering you for things that unfortunately can happen, or the perception on the patient saying, I think they did the wrong thing, so I'm going to sue them. So your malpractice insurance people will step in and say, well, we'll protect you, defend you in that sort of legal sense, and if something needs to be settled out of court, then they'll make the payment for that. So that's what your malpractice insurance is for. The APA, and you know, for people to come on our course, everyone has to be registered, and everyone has to have malpractice insurance. They're basic requirements to attend our courses. We have a sort of standard that we have. I don't let massage therapists or exercise physiologists come on the course because they don't have the skill set that I need them to start with to move them to the next level. So the APA, we have our guidelines which was set up. We set them up about 5 years ago now, to sort of make sure we had a basic standard training, and that comes to the 2-day course of dry needling, or the 150 hours for those people that want to do traditional Chinese medicine. And it's always staying within your scope of practice. So if worst came to worst and you had to stand in front of a peer review panel, the first question they would be asking is, well, the technique that you performed, had you been trained in it? How did you learn about it? What sort of examination was involved in that process, and those sorts of questions. So it's not good enough to say, oh, well, we had a Friday afternoon service and somebody went a course for 2 days, came back and taught us in half an hour, and I've been doing it since then. Well, obviously you can't learn 2 days of work in half an hour in service, So that's not an adequate training. You've got to know the anatomy, you've got to think about the complications that are possible, you've got to have structures in place, you need to be watched, you need to be observed, and ideally have a skills-based assessment at the end of it as well. So they're all the sorts of things that we have in our ones. Great. Did you have a question? No. The WA Health Department, which is the health department here, does have 3 key things that they ask for. One is to swab the area, use a single-use sterile needle, and appropriately dispose of that needle. Now that usually applies more to those groups that don't have national registration, so tattooists, body piercing, those sorts of groups don't have a registered body that sort of regulates what they do. As physios we do, we have national registration, but I still advise all my students that they follow that just in case something happens. They can always say, yeah, we've got national registration, but we also follow what the WA Health Act requires of people in a similar situation. Okay, how does it affect people? So this is sort of giving you a little bit of an outline of the types of mechanisms that are triggered when a person has a needle put into them. We talk about things at a local level, so at the actual tissue. We talk about the segmental level, so where it happens at the spinal cord level, and also what happens in the general body in regards to that needle. So at a local level, there's an increase in nutritive blood flow. And you can see that, like if you scratch yourself, what do you notice around it? Yeah, you get your histamine response. So you get a release of histamine, you get an increase in circulation, and there's that red wheel effect around it. Well, that's due to an increase in circulation. We know from Jay Shah's work that there's a change in the chemical milieu. So we know that those chemicals change from being higher concentration, and then following the needling they become a lower concentration or normalise. At a segmental level, we also know that when you stimulate the sharp sensation in people, which is what the pin does, it stimulates a particular nerve called the A deltas, which are thinly myelinated and reasonably fast conducting. And they're the things that when you put your hand on a hot stove, you go, ooh, and you pull your hand away. It's like a reflexive mechanism. So it's part of our protective response. And in response to that, in our spinal cord, part of that A delta will synapse with an encapsulinergic inhibitory interneuron. So it produces our own opioid system, and part of those opioids will suppress the pain that is then passing up into the brain for analysis. So that's a postsynaptic inhibitory interneuron, and it's an opioid-based system. Once that pain hits the brain, then we say our brain's going, well, we need to deal with that. How are we going to deal with that? We're going to deal with that through our descending inhibitory system, which you guys have probably come across. It comes down through the dorsal column. So the descending inhibitory system is something which stimulated in the sort of midbrain nuclei, and from those that descending impulsion comes down, and that stimulates our inhibitory area, but it has the same effect of affecting pain reception. We also know that when you put a needle into a person, it's space occupying. Things that move tissue around stimulate our large alpha motor neurons, and they're also linked into our pain gate theory. So when you use TENS, you're using skin sensation to depress the pain sensation. When you walk through a doorway and you knock your elbow, after you said some sort of expletive, you start rubbing it vigorously, and that's what you're doing. You're blocking that pain through large mechanical mechanoreceptors activation. So they're ones that you would be familiar with. Going outside of the segmental level, we go to supraspinal, so it might be up in the brain or just generally got our inhibitory system, DIS, which is sort of what we just talked about. We've also got a diffuse noxious inhibitory control system. Have you guys come across that at all? Yep, so what's your understanding of that? Yeah, Brew?
Basically, if you apply a painful stimulus somewhere else to the body,
Yeah.
like they receive that pain over the other one,
Yeah.
that distracts it, basically.
Yeah, so it's called a counterirritant theory. So you can do something like this, you know, you can have our special treatment for $150 where we'll do one-off treatment of acupuncture, or for our diffuse noxious inhibitory control system, you can hug the cactus as hard as you want and get a general stimulation. So that's a good little cartoon to remind you what the diffuse noxious inhibitory control system is. It's non-specific, it affects the whole body, and it doesn't really matter what the stimulus is so long as it's strong it's going to activate that opioid-based system. We've also got our autonomic nervous system, which generally we sort of see as a sympathetic overactivation, and these patients come in with hypersensitivity, often sweating, often with swelling. So you know them, the skin's discoloured, the pain levels they're describing are out of proportion, they're often quite avoidant of using the limb, either the foot or the hand most likely, and we can actually try and stimulate the opposite of the sympathetic, the parasympathetic, and that's going to then gate down or suppress down that sympathetic nervous system. So that's just something that people are starting to look at, and we can do that via stimulation of the vagal nerve, and that's more traditional Chinese medicine. Serotonin we know is a feel-good hormone, and we know that when we stick needles in people, it doesn't matter we stick in lots or a few, lots of stimulation or minimal stimulation, it has the same effect on the serotonin system by increasing it. So we also know that there are some conditions sort of like Fibromyalgia Syndrome, particularly in women, where they have a lower serotonin system, and serotonin is a neural synapse chemical involved in the descending inhibitory system. So if we don't have much serotonin, we don't have a very effective descending inhibitory system either. So if we could stimulate more serotonin, for some people, that would be pretty good as well.
Sorry, just with the DIS, what does that stand for again?
Descending inhibitory system. So it's a system, so it's not one thing, it's like the thalamus, periaqueductal grey, nuclear raphe magnus, dorsal columns. Yeah, so it's just a system. Is that right?
Yeah, I know, I just couldn't remember the abbreviation.
Yeah,
Still saying it.
fair enough. And DNIC is a diffuse noxious inhibitory control. Okay, so what's the evidence with regards to using dry needling? So I've just taken a few from the Cochrane reviews. If you look at headaches, they've done back then it was a recent review, 2009, where they had some additional trials to add to the previous review, and they came up with a conclusion that acupuncture would be a valuable non-pharmacological tool in patients with frequent episodic or chronic tension type headaches. And the same with the migraine, that basically it's an effective treatment to be utilised. It does come with the benefit of minimal side effects. So if people are not enjoying the migraine medication or the opioids that may be prescribed, it's certainly one to look at with regards to managing their migraine pain symptoms. And of course, if you look at migraines, it's a stress response. So if we're adding stress to the glass, once the glass gets to a certain point, it doesn't matter whether it's a speeding ticket or the mother-in-law dropping by for dinner, or your cat getting run over, that last little stress is enough to crank up a response. Too much stress, you get a cortisol response, your adrenal glands get worked, and you get, pain gets magnified. So if we can look at that sort of model, what we're trying to do is reduce any form of stress. And if trigger points are part of that stress response, if poor coping mechanisms are part of that stress response, if perceived psychological threats are part of that, any way in which you can minimise those stresses are going to have a beneficial effect. And in this case, the person might have migraine when they get a stress response, somebody else might have back pain, different sort of presentations occur simply because stress gets out of control. When we look at specifically at dry needling, this is a randomised double-blind controlled trial, which is pretty hard to do with any sort of treatment, let alone needling, because to do a double-blind, you've got to have the observer blinded, the therapist blinded, so that group, and you have the patient blinded. Now, if you've had needles put into you before, you know whether you're getting acupuncture or not getting acupuncture. It's not sort of like take the green tablet with the medication in it, take the green tablet without the medication in it. So it's pretty easy to do double-blinded studies if you're doing drug therapy, but acupuncture is very difficult. And so some of the ways they try and blind the patient, therapist is okay. One person assesses it and marks where to treat it. Another person comes in, does the needles where they've been told to do it based upon the marks on the body, and then that person then comes back again and reassesses the range. So it's easy to blind the therapist as to whether in the control group or not the control group, but it's very difficult to blind the patient. So the patient either has to be acupuncture naive, meaning they have no idea what a pinprick does or doesn't feel like, or you use some sort of distractory thing like a retractable needle that when you push it into the skin actually comes back up into the shaft, or you push a toothpick on so it's non-penetrating, or a blunt needle. And then one of the novel ones that we'll have a look at in a sec is they actually they do the general anaesthetic, so the patient didn't know whether they got it or didn't get it because they were knocked out. So we'll have a look at that in a sec. But this was a randomised double-blind. Their control group was that they used blunt needles. Now there's a bit of argument out there in the research, but even just pushing a blunt needle onto a person's skin is going to cause some sort of sensory input, and that may be enough to stimulate some sort of response in the tissues as well. So having a control group is very difficult in acupuncture for those reasons. But they basically came up with that in this randomised double-blinded controlled study, 6 treatments over 4 weeks, which is also clinically a relevant amount of time. The visual analog scale decreased significantly from start to finish, better in those that had the local twitch response. So that was the study that found that that was the case. The sham, which is the control group, also had a reduction, and they looked at SF36 and those sorts of things. So pretty much what we're tending to find, unfortunately, is that control group here gets nothing. Placebo control group gets some sort of intervention which is non-direct needling, so blunt, toothpick, retractable needle, and then you get your true intervention group. And what they're tending to find is that these two groups that get some sort of input, needle-wise, true or sham, get about the same sort of result, and both of them are better than no intervention. But the argument at the moment is, well, if you can get some intervention by putting a toothpick on somebody, why not do that to everybody? Why go through this process of training and using needles and da-da-da-da-da? So that's kind of where the research is sitting at the moment. But the thing is with that, it's taken a long time to get to this point to realise that these two groups are the ones we need to work on. Normally we just look at intervention and no intervention as far as an effect. So this was the other one, we're looking at the total knee. So they're going for a total knee arthroplasty. And what they noticed with these people is that they have a lot of trigger points before surgery. So they thought, well, what a great group of people do. What we'll do is we'll get a mass prospective, randomise them as they come through the door, the randomised ones that go to the actual intervention. Some therapists will palpate standard muscles that they looked at. If they've got a trigger point, they'll mark them and da-da-da-da, and then they'll go into the surgery. There'll be another therapist in there that will be told intervention or no intervention. So if it's an intervention, they'll actually do the needling on the patient. If it's a no intervention patient, they won't do anything. And then the person will have their knee surgery, da-da-da, and then they'll go out into recovery and they'll assess the physio that did the first markings, will then assess the patient and follow them up over the next 3, 6 weeks, whatever it is. And so the patient didn't know whether they were intervention or not because they all had markings on their body, but they were knocked out, so they didn't know if they had actually needles put in them. And the only person that did know was the one that did it, but that person had no role in assessing or re-evaluating down the track. And it's the same thing here. They found that outcome measures at 1, 3 and 6 months, a significant reduction in pain and medications at that first month period in those patients that actually had the dry needling as opposed to those patients that didn't have the dry needling. So that was like a very novel way to get around the problem of whether the patient does or doesn't know they actually had the surgery. The problem with reading that research is that they really would have been nice if they had another group where they had sort of needled the other leg or needled somewhere else, so we get the diffuse noxious inhibitory control system activated and see did they do as well as the ones that had the specific needling. Maybe that's what they'll do next. Yeah, or toothpick or blunt needle. Yeah. I mean, there's arguments for and against. I'd rather they perhaps did needling, but there's also, we know that, say someone's had a mastectomy, so they lost their lymph nodes on that side, we don't want to put catheters or vaccinations or needles in that arm at all anymore. But if they've got tennis elbow here, we know we can do, say, C5, C6 at the neck, because that has neural flow to that point. And we can also do the contra-limb side at the same point, because there's a crossover effect in the brain in regards to that as well. So if they did a study where they said, okay, well, this is the operated knee, we'll do the unoperated knee in the same trigger points. But that acupuncture would say, no, 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 don't do that, because we know that's how we treat that limb. So it's kind of hard in some ways. They'd almost be better off to say, well, we do 6 points in the leg, let's just do 6 points randomly in the shoulder, you know, anterior and posterior deltoid, biceps, da-da-da. Just do the same number and then use that as the control group.
So the patient's like in a situation where you wouldn't want to puncture the skin, like
Yes.
a reason
Yep.
why you wouldn't.
Yep.
That's the reason why it'd be good to prove the effect of something like a toothpick or a blunt needle, because if that's
Yes.
quite effective, then that might be a good way of treating those patients.
Yep.
Maybe not as effective, but
Yep. No, that's true. That's true, because you're still getting a skin response. And this was a systematic review that's just been written up in the Journal of Sports Physical Therapy. Based on the current best evidence, we recommend, which is their grade A, dry needling compared to sham or placebo for decreasing pain immediately after treatment and cautiously at 4 weeks in patients with upper quarter myofascial pain syndrome. So it's just, yeah, there's strong evidence out there, as good as we can get at the moment, which is a growing body of clinical evidence and research to indicate the effectiveness of dry needling as a modality. But certainly there's a need for ongoing and further studies to determine its mechanisms and also the clinical cases that it's appropriate for and sort of what protocols to follow. So we're always trying to look for evidence-based medicine, but research always lags behind clinical practice. And you would know that, there's lots of things that you get taught to do, and if you sort of said, but what's the evidence, what's the evidence? Sometimes it comes down to, well, the clinical reasoning shows that to be effective, so that's what we're doing. If we waited around to be absolutely proven, well, there'd be nothing done in medicine, full stop. You know, and you start to look out there in the broader medical picture, and there's lots of things that, even just a number of non-steroidal anti-inflammatories that get handed out, you know, there's lots of evidence that say in most situations that shouldn't be done, or the number of x-rays to get prescribed, you know, it's like that for a lot of things. So the evidence is pretty good. There's a lot of big journals, Pain, Spine, Journal of Sports Physiotherapy, that have, you know, ongoing articles being produced about and to do with acupuncture and dry needling. And there's definitely, you know, an enthusiastic discourse on a lot of professions in the usage of it for the control of pain, if nothing else. And if somebody wants to act as a volunteer, now this is I'm quite happy to video practical demonstration of, treating on how we do gastrocs, medial-headed gastrocs. Like to do. So you can palpate the medial-headed gastrocs. We use what's called a pincer palpation. So you localise the trigger point between thumb and index. Move your thumb slightly away to expose it, and then needle down towards your finger. So you're actually directly aiming for what you felt was between your fingers, and in that way you improve your accuracy. Gastrocs is a pretty big muscle, so you can fan along it if you find a trigger point like it's a taut band, so you might get one, come out, move up it and move down it to pick up different areas. You can also needle the same muscle anteriorly, so it kind of depends a little bit in which position you were when you're palpating and assessing the person. Either is fine, it's just we try and teach a few variations so people have a bit of a variety of ways in which they can address a certain trigger point if for some reason they couldn't, so you can see the response from the patient there. Now this last one, I'll point out where you're looking for, but you'll actually get to see the local twitch response in the patient as the needle goes into the trigger point. So you've got to watch the space between my fingers just over here. So when my hand goes back on there, you just watch that space through there and you'll see that twitching. Yeah, so that's like a local twitch where it sort of physically twitches and contracts. Some muscles are stronger and bigger than other ones, and the classic is definitely the calf muscle, because it's such a long strap-like muscle that when it twitches you get quite a length of muscle moving. You get this supraspinatus and quads and iliopsoas and that as well, depending upon the muscles. Okay, so does anyone have any questions that they wanted to clarify from that? Yeah, Ben.
I was just wondering about like tension headaches. So I just remember when we got taught about them, they just briefly said that we don't really treat them.
Don't treat it, yeah, exactly.
So we just didn't really go into it at all.
Yeah, well, your definition of a tension, I mean, there's the International Headache Society, and they have their classifications of headaches, and tension headaches are things like, you know, taut band, there's a specific criteria that they will have. That's all fine and good, but they actually don't have a definition for cervicogenic headache. So a neurologist wouldn't describe a headache source as being the upper cervical joint. To have a stress level, and when the next stress event comes along, it just provokes, it could be a tension headache, it can be a migraine headache, it could be a cluster. I sort of see those as all just descriptions of a person under stress. If you can change the stress elements, of which one may be a musculoskeletal component, it might be a postural component, it might be an anxiety component, but it's all going to feed into that system. And as a physio, you can definitely address those things. Yeah, sure, sometimes it might be a vascular component that we may not deal with, but you'll start to find that all patients will have a component of anxiety and stress in their chronic problem, and if you can help them manage that, come to grips with it, learn the coping strategies, you'll help a lot of people.
Ask for like dry needling, let's say, like, do you see it becoming like that, so big or so essential that they would teach it in a uni course, or like most physios would be using it? Because like some physios don't even, wouldn't even use it, but they seem to get by, or like we're not getting taught at uni. I'm not saying that's bad or anything, but like, do you see it becoming like that big or that?
It will be that. It is definitely, like, compared to 10 years ago, compared to 5 years ago, yeah, it's huge, particularly so in Australia. As far as the undergraduate goes, I've been asked by the guys at Curtin, would I teach it at an undergraduate level? And I've said no, because I think you guys got enough skill development to gain that you don't need another thing on top of it. So I think you need to learn to integrate a lot of your assessment stuff with patients. And then you might come back and say, okay, well, now that I've got that under reasonable control and I've got reasonable handling skills and I can feel things, then I would look at extending it in that way. So I think as an undergraduate level would be wasted on you in that sense, because I don't think your skill level's there yet to feel a lot of the stuff that we'd want you to be feeling, and that just comes with time. So yeah, I just, I see that when people are coming through the courses every year, and I feel the handling skills, and I see the handling skills, and I see how they hold tissue, and some people really struggle. So I think generally in the undergraduate level, maybe like in gym, because they're just a bit more mature, they've done a few more things. But it's amazing how maturity does change your perspective. So even a physio that's only been out for 2 years, but came into it in their 30s, they do things differently to someone that's just come straight from high school to university to the workforce. It's just a different approach. Sensitivity, more life experiences, more understanding. You can find other useful information under the free stuff section at www.aapeducation.com.au, like outcome measures and screening tools. And also under the membership section, you can join as a free bronze member and have access to the large resource library. I hope you've enjoyed this presentation, and we look forward to hearing from you in the future. Bye for now. I don't see how you can survive without it. And I see lots of therapists that come in that say, wish I'd done this, 15 years
so
ago.
Would you say like, without, say you were physio, muscle physio, you didn't know acupuncture.
Yeah.
Would you say that some physios would have no alternative treatment, or like they wouldn't be able to get, like would they not be able to, do you know what I mean? Like would like massage and mobilisation not cut it, or?
Yeah, because when you do, you can, and that's where I've lucky in the sense that I've done the mask, I've done the specialisation, I've seen all that stuff. And I'll get patients sent to me that have had 6, 8, 10 weeks of musk physio, ultrasound, manual therapy, MINIPS, just hasn't got it. You go in there, you do a couple of acupuncture needles, done, settle down, off they go, back to their whatever program it was that was needed. It's often the thing that gets a person over a hurdle onto the next level. So it's a great intervention like that. It can make a jump start to a new level, new ability. So I'd be lost without it. And I certainly know that a lot of people that come on the courses that come back, because we have, in our advanced courses, we have basically now we do little 5-minute case presentations, and it's just interesting going around the group and seeing what people are doing that they couldn't do before with patients, satisfaction-wise. And then there's a basic thing to it, it's your hands. Your hands really struggle to do a lot of manual therapy. When you go do, 2 minutes later, boom, 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 done. Your thumbs haven't died in the process. So generally it's a lot less traumatic on the patient. It's certainly a lot less traumatic on your hands. And when you're not doing something with your hands, you can be doing something orally. And I think there's a lot of education that needs to be done for patients. And so by doing, needling, it gives me an extra 2 or 3 minutes a patient where I can do that stuff. And then, or at the end of the day, that's 20 patients, an extra hour. So you can decide, spend more time with the patient on education, do some continuing education, go and kick the footy with your kids. It's a time-saving thing as well.
So you would use it that often through a day? Most patients at some point?
Most patients, if they're coming to me with pain, would probably have some sort of dry needling, because most people have got musculoskeletal problems. If it's a back injury, we got a needle at segmental level that's sore. If they've had an acute calf strain, about 30% of calf strains are actually just muscle spasms. You can treat it until the cow comes home with normal physio, but until you put a pin in there, it'll stay there. If it's a shoulder problem, they might have an impingement signs, Hawkins and Kennedy's, Job's, near O'Brien, they might all be positive, but when you actually palpate it, you feel it's only sore on the muscle, it's actually not sore on the tendon. You needle the supraspinatus and they'll regain their full range, they'll lose all their impingement signs, and it'll be gone in treatment. Whereas normally you might sit there doing your stuff for 6 weeks. Yeah, so once you start looking for it, you start to realise what a large proportion it is of your caseload. And it's certainly quick and effective if you get the right ones.
Did you commonly use it with massage? Or you either do one or the other?
Do you know what my talk tomorrow night is about, the APA?
Yes, because we're going.
Are you going, eh? Yeah, so that was actually kind of an eye-opener for me to sit back and actually look at that, because I've never thought of it from that perspective. And I've spent weeks on that talk just trying to work out where I sit with it. So I'll tell you tomorrow night.
Okay. What's your one tomorrow night, sir?
The APA has got me doing, the sports physio group's got me doing a talk on massage and dry needling indicators,
Is that a 4th year one?
No, it's just the APA. So only APA members, I think.
Yeah.
Students and, yeah. Oh, priorities.
To go.
I believe it's full anyway.
Do you find a lot of patients are hesitant when you first suggest dry needling?
Yeah, it's part of the consent process. So you would do your examination, you say, as a result of my examination, what I'd suggest that we do is some dry needling. Have you had dry needling done before? Yes or no? And more people have. So then I'll be like, well, if you haven't, it's going to involve this sort of process. This is what I'm expecting from it. These are the associated dangers. So you do the pros and the cons, so you get education, informed consent. And then if that's okay with them, yeah. And very few people would say no. Occasionally somebody might be hesitant. I say, fine, let's leave it. You can have a think about it. I can do something else today. A very, 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 very small percentage might say no outright, and that's either for religious reasons sometimes or bad experience from previous interactions with the medical profession. And if it's still an issue after a week or 2 weeks, I'll come back and sort of say, look, we first discussed this a couple of weeks ago and you're pretty hesitant. How do you feel about it now? And they might say, yeah, that's okay, just don't want to look. Or I had a bad experience, but I'm okay with you. So there's a bit of a rapport building process to it as well.
Would you demonstrate on yourself?
Yeah, if they want to. If they say, look, can I see what it looks like? Fine. Most people say you can do it, but I don't want to look at it. That's the reverse. They don't want to see it. You know, that's where and then you got the person like, oh, can I have a look? You know, like, no, you can't, because you're twisting your whole body, and it's not very handy to put a needle in a muscle that's all twisted and working hard. So, Prue.
So to practice on that tier of your introduction course, so you would do the lower limb course, and then you do the upper limb and the lower limb, and it's after having done that, like at what point can you start using it in?
From the introductory course. So the introductory refresher course, once you've done that, you can start dry needling, because that's our minimum requirement. It's a 2-day course. But that's when you stay within your scope of practice. So you would needle supraspinatus, quads, calf, extensors. So the muscles that we go through in that course, then you would go away and start practicing that. Now, if you find it's useful and you want to learn more, then you come back and do, say, the advanced course. And it's not advanced in the sense like it's a higher course. It's just that you can't cover everything in 2 days. So then you go back and you focus on the head, the neck and the limb and the abdominals and the lower limb. So it's more just dividing up the area into 2-day chunks that people can digest and then go away and utilise. We've got 4 girls that have come down from Singapore for these whole 6 days. So they just come down and do all 6 days and then they go back. Some people come and do a course and then 6 months later do another course and then 6 months later do another course.
So it's only the last one you have to do?
The master, yeah. So to do the masters one, you need to have done both advanced courses and practice for another 12 months. So I want people coming back saying, oh, I've done this and it's good and it's not good, and I'm not sure about this, and it's more of a consolidation thing. No, they've done 95% of the stuff. It's more on case presentation, some autonomic nervous system, some different muscles. They get a chance to request specific reviews. They have to do assignment, case, so it's more of a bringing things together sort of thing, rather than a whole bunch of new muscles, so to speak, to learn.
I just asked about do you know your stance? Do you know how there's people who practice Chinese medicine or whatever? How does it differ from the one? Wouldn't their theory be different?
It's totally. That's why the TCM course, our recommendation is 150 hours.
How do you feel about the way they do it? Is it still effective or
the research for them is probably a bit thin.
It's a bit iffy, or?
Look, it's got its place. It's got its place. So again, we don't say that because there's no research, it's not effective. So it's more, some people would argue just outright, well, if it works for them, why not do it? But the argument out in the research community is, why should we be spending lots and lots of thousands of limited research dollars researching something which obviously hasn't made a measurable difference? And that's an argument, sure, but it's not going to stop the research because people want to know.
Do they treat, because you're treating this obviously for physios, what are they treating it for then?
Gallstones, migraine, period pains, liver diseases, cirrhosis, cancer, anything that you see a GP for in a Western medical model, you would go and see a traditional Chinese medicine practitioner. So it's much broader than musculoskeletal or neuromusculoskeletal.
And they actually practice this in WA?
Yeah, you've got traditional Chinese medicine practitioners that you go to because your eyesight's failing or your liver's not functioning effectively.
Once you've done the introduction course, are you required to do a refresher after 3 years?
No.
No.
It just goes on your PD. So you need to get 20 hours of PD a year. So that plus reading some journals, plus going to a couple of in-services, plus presenting to your work group about, orthotics, you just accumulate 20 hours a year and this would just be part of it. So it comes back to you as a professional sort of thing, oh, okay, I did that course 5 years ago. Do I feel comfortable about putting needles? Not really, so I'll go back and do it again. That's fine. I tend to encourage people not to. I say, look, no, if you've done the introductory course, unless you're really, 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 really unhappy, you're better off just to go to the advanced course, because it's not advanced as in it's harder, it's just more stuff. So you're going to pick up what you did, and you can go back to your manual. It's just more you've lost the confidence to put the needle in, so you have to go back through the anatomy, because it's all about anatomy. Putting a needle in is easy. Anyone, you could do it here. It's what you're doing with the needle that's the problem. So it's more if you've got good anatomy, you've got good surface anatomy, you know your tissues, your palpation, you can check the arteries there, you can muscle test there, you localise it, and then you needle it 3 centimetres. So it's a process that you go through, and that just takes practice.
Do you find yourself treating the same patient regularly for the same problem?
Not me.
Okay.
I'm a real bastard when it comes to chronic pain. Like if they don't toe the line, I don't treat them.
Because in one of my clinical placements, I find that there are lots of people that come in just wanting acupuncture as like a quick fix, and they don't want to practice like posture, or they want to.
I've got a rule in my clinic that if you don't do what I ask you to do, I won't treat you. I'll say, look, I don't want you to ruin my good name, so if you don't want to do what I'm going to ask you to do, I'll give you the name of a few other physios and you can go to them, but I'm not going to treat you, because you're not going to get better. And I only want people to get better. So they've got to accept responsibility. Yeah. Otherwise, it's going to blame you. Oh, I went and had that, it didn't get better. I don't want that. So I only treat people that are compliant.
So outright, you'd be like, this is just part of the treatment. You have
Absolutely.
to have and stuff.
Yeah, it's only a pain relief. It's only a short-term mechanism. To get long-term mechanisms, we need to talk function, habit, strength, flexibility, mental things. Yeah, they're the long-term features. But the beauty with this is if you can change a person's pain short-term, they're going to listen to you. They're going to take what you say longer-term with a much more open mind. If you can't change your pain, well, shit, what do you know? Why would I do all those exercises if you can't even change my pain? So if you can get the person to be compliant, and that's where acupuncture is really handy, then they'll take on the hard yards as well, generally.
Is there an age limit on how young a person you can do dry needling?
It's not a legal thing, it's more that with anything we treat 14 to 16 there's a grey zone, so if they're 14 to 16 you've got to get parental consent as well as child consent. If it's under 12, it's mainly under 12 to 14 it's more child, you have to get parent consent. When you get that 14 to 16 you've got both consent, and when you get to 18 it's just the person's individual consent. It's more how do they feel about needles, it doesn't matter what the age they're at. So your options are you could use laser if they were really concerned. So I don't have a big paediatric population at all, and I tend not to needle them because I don't want them to get a perception or a fright of the medical profession. So it's more a sensitivity to that side of it rather than being, don't do it because they are such an age. If I'll offer it if the parents are okay with it and the kid's okay with it, sure, it's no problem. I mean, my 18-year-old won't touch it, my 14-year-old son will go for it, no worries. Want to play footy on Saturday, stick him in. My 17-year-old son's like, don't do that. It's going to hurt. So it goes more down to the person than the problem. But the other thing too is that you don't see trigger points much in kids. There's an age factor that we don't know why, but you don't see trigger points really until they get to 14 to 15. And then obviously as we get older, they become much more apparent. And then we get, 50s and 60s, we get spontaneous trigger points, which are cramps, nocturnal cramps. Ooh, you jump out of bed, that's a cramp. Put a pin in that, it's like, So as we get older, something's happening to our tissue that makes us more prone to trigger points. When we die, we've got trigger points. When we're born, we certainly didn't have them. So something's happened chronologically, we don't know why, but it certainly does get more as we get older. All packed up?
No, I was just thinking that.
You sure? No, that's fine. So you got to take a pizza with you though. Everyone's got to walk out with the pizza box, even if it's just for their dog. So anyone other questions? Sure, Prue? Not got one more? No? All right. In the piece of paper that you got there, you got some information there that's sort of along that line. If you'd like, there's a 10-page report which is sort of titled around infection control, acupuncture and dry needling. So you can go to our website and you click on that and you can download it, but it'll also enrol you in our 2-weekly clinical kit, which is like an e-zine I send out just did one on concussion, another one on different topics, some to do with needling, some to do nothing with needling at all, outcome measures and that sort of stuff. But if you sign up, get the report, you'll also be lined up for that. And that'll keep you in contact with us. And apart from the e-zine that you'll also get little notes about what courses are coming up. So like we've got Mark Oliver's doing a TMJ course in a couple of weeks' time, and then Peter Osselback's doing an ultrasound course in about a month's time. And I'm trying to get a guy called Phil Gable, who's done his PhD in outcome measures and screening tools, to come across and do a talk about that as well. So yeah, it just will keep you in contact, I guess, if you want to.
Do you do it a lot on geriatric patients? Needling on geriatric patients?
Yeah, they're old. They got muscles. Yeah. We've got two. One of the Singaporean girls is a vestibular physio, so she's interested to have a look at just upper cervical and cervicogenic and just balance stuff. And then we've got another lady who works on strokes. She's in a neuro ward, so she wanted to have a look at it, to look at on her geriatric stroke patients as well. So yeah, I mean, it's just a muscular system. Geriatric people get older, they get trigger points more frequently than younger people. But you still overwork that with their strength, their balance, their coordination, their posture, the hydrotherapy. It's all the same. It's just another intervention you can use for pain management. But yeah, it's still fine. I love it. All done? No more questions? All right, well, thank you very much for coming along. And we'll see you guys around. All the best for your final exams, for most of you, bar Justin and Melanie. Don't forget the pizzas. Justin, like, we're all going to roll you down the stairs, mate. Did you eat all that? I was going to say. You would have done well if you had have eaten it.